Okay, so our next talk, Dr. Patrick Foy is here from Fredert Medical College of Wisconsin, and he is an assistant professor in medicine at the Medical College of Wisconsin, Division of Hematology and Oncology. He specializes in the treatment of bleeding and clot disorders and has an interest in lung cancer. He's a native of Milwaukee. He graduated from the Stritch School of Medicine at Loyola University Chicago in 2004, and then he completed an internal medicine residency and hematology oncology fellowship at the University of Minnesota in Minneapolis. During his final 2 years of training, he was awarded a position on the National Institute of Health Hematology Training Grant. Dr. Foy.
All right, thank you all for having me. I am a hematologist, so we're going to talk a little bit about GI bleeds, and I'm not the ideal person to talk about GI bleeds because I'm a hematologist, but we'll cover that briefly, and then we'll talk mostly about iron, because iron, I think, is essential for everyone with HHT, and it's, I think, the most misunderstood molecule that's out there. So we'll talk a lot about iron. We'll talk a little bit about how iron is important for treatment of HHT. All right, so let's start with a case. This is one of my patients, a 48-year-old healthy female with HHT, goes to her primary care doc with fatigue, shortness of breath, particularly this, what we call dyspnea on exertion, or a functional decrease in exercise capacity, right? So she's used to going out a bunch and now just can't do what she's used to. She thinks her HHT has been really well controlled. She hasn't had any recent nosebleeds, can't find any additional sources of bleeding, but she's really starting to feel run down. Her menstrual cycles seem normal. She's restless at night. She can't fall asleep, and she's chewing ice. And I think we hear this story all the time, right? The chewing ice thing. We'll talk about it. All right. So you look at her labs, and the most accurate way for us to measure someone's blood volume is to measure their hemoglobin. And 3 years ago, it was completely normal at 13.6. And a year ago, it was kind of on the low end of normal. And then 8 months ago, when she had a procedure done to her nose to stop her nosebleeds, which seemed really effective, her hemoglobin was normal. And all of a sudden, now, months later, half a year later, her blood counts are down. What is going on? Well, this is iron. This is why iron is so misunderstood. We can see that over time, her iron levels, her ferritin, which is the best marker we have of iron stores, had been kind of on the low end of normal, and they slowly are climbing down. They're falling very, very slowly. So what is it that's driving this person's anemia? We'll talk. All right. So what is anemia? Anemia is simply the term for a deficit, a deficiency in either the total number of red blood cells you have or the protein in the red blood cells called hemoglobin. It's iron deficiency and anemia is the single most prevalent blood disorder. About a quarter of the world's population at any given time is anemic. And symptoms vary. Different people will get different amount of symptoms based on what the number is. So I try not to focus much on what the number of your hemoglobin is. It's really what is your baseline, how quickly your numbers have fallen from the baseline, and know that different people will have different symptoms at different numbers. All right. When we look at blood, this is one of the most powerful tools I have. I can just look at blood under the microscope. It's incredibly easy to do. We can do it in my clinic. Any lab pretty much in the world can make up a blood slide really quickly and have an experienced provider take a look at it. And this is what it looks like. So you can see all the pink-colored donuts. Those are red blood cells. And that is a fairly normal-looking blood slide. You can see the larger cells with the purple dots in there, those are, yeah, we can use the pointer. Sure, so all of these up here are red cells, and then these larger cells with the purple colored nucleus, those are white blood cells, those happen to be neutrophils, and then there are lots of little cells, the little specks that are harder to see there, those are platelets. And this can be really helpful because different types of anemias will have very different appearances when we look at them under the microscope. All right, so I'm pretty simple. All right, when you have a low blood count, you've got one of three things happening. You're either bleeding, or you're destroying blood, what we call hemolyzing, or you're not making blood. It's got to be one of those three things. So if your blood counts are low, you're either bleeding, hemolyzing, or not producing red cells. And in HHT, I think we all recognize the first problem, but not the most important problem, is bleeding. All right? So I don't think of HHT as a bleeding disorder, okay? The coagulation mechanism is completely normal in the vast majority of patients with HHT. What this really is a blood vessel disorder, right? This is a problem with vessels that have developed inappropriately and are prone to bleed, not because there's anything wrong with the blood, but because there's problems with those blood vessels themselves. And we know that bleeding is really common. We just talked about epistaxis and how prevalent it is. We know that virtually everyone with HHT has some degree of nosebleeds, and that lots of the general population has nosebleeds as well. We know that the blood vessel malformations that we get aren't confined to the nose, and that it's a systemic problem, and that abnormal blood vessels can really appear in many different tissues. Roughly speaking, 80% of patients with HHT will get abnormal blood vessels that develop somewhere else along their digestive tract, most commonly in the small bowel or in the stomach, but in the colon as well. But what is really interesting, and for reasons I don't think we fully understand, only about a third of patients with HHT will have prevalent bleeding from their digestive tract, whereas nosebleeds are much more common. If we find blood vessels in the lower part of the digestive tract, we don't really know how often they are significant for bleeding. And these can be very difficult to try to understand and find, right? Because these are not squirting blood vessels, right? When we think of bleeding in the movies, we see these arteries that are pumping blood out. That is not what we're talking about in HHT, and it's certainly not what we're talking about along the digestive tract. These are little AVMs, right, that just ooze, and they just ooze and they ooze, and unless an endoscopist is actually in the lumen of your digestive tract and can see that while it's oozing, it is very possible to miss bleeding from the digestive tract on a scope. So we know that very often we'll have occult blood loss where we can't see it, right? We're losing blood probably from the digestive tract and it's not visible. If that bleeding occurs in the upper part of the digestive tract from the stomach or from the first part of the small intestine, on occasion we can get what we call melena, which is the kind of consumptive process of red blood cells as it passes through the digestive tract. Melena has the classic black tarry stool appearance with this distinct odor. If you've had it, it's hard to forget. It is different than what stools look like if you're on oral iron supplements, right? It's much softer and definitely has that unique smell to it that iron does not cause. If you have bleeding from further down in the digestive tract, from the latter part of the small intestine or from the colon, often that will be bright red or what we call hematochezia. All right. How can we look at this? Well, an endoscopist can do a EGD where they pass a scope through the mouth, down the esophagus, and into the first part of the small intestine, go through the stomach and into the first part of a small intestine. The scopes have a light source and a camera and then a tool port where they can use different techniques to identify bleeding and clip blood vessels, perform cautery as they need. It typically requires light sedation, and you can see pictures like this. I don't know how well that projects there, but this kind of red vascular lesion is what a AVM would look like on an EGD there. The procedure itself is pretty quick. Takes about 10 minutes or so. 10, 15 minutes to do. Obviously, for a patient, it takes a lot longer to come to the hospital and get into the gown and get into the right place. But the time that the procedure is done is very, very brief. If we can't, we usually would recommend in the setting of HHT, if bleeding is disproportionate to what we would expect with just nosebleeds alone, to start by looking at the upper digestive tract first. We know that most of the time when HHT patients have bleeding from the digestive tract, it tends to be in the stomach or small intestine much more commonly than it is in the colon. So we'd start usually with the EGD first, the upper endoscopy, and if that doesn't help us identify additional sources of blood loss, then we can proceed with two other potential studies. The first is a colonoscopy, where we would pass a similar type of scope to the EGD through the rectum and evaluate the colon. This procedure requires the prep, so it's a cleansing prep that patients will take so that the endoscopist can visualize the walls of the colon. That procedure certainly requires some degree of sedation. And then there's a capsule endoscopy that we can do where we pass a camera pill. You can either swallow it or they can deploy it via an EGD scope. And then as the camera passes through the small intestine, getting to parts of the digestive tract that can't otherwise be seen with the scopes, the pill actually takes photographs every few minutes, and as it goes along the course of your small intestine, it records those and it gets captured on a device so that an endoscopist can review the pictures and see if we can identify a source of bleeding. What do we do if we have bleeding? Well, there's a whole bunch of different things that we can do locally. We had talked about treatments for nosebleeds just a second ago. We can use the scopes that we have available to us to perform cautery of blood vessels, but there are a number of medical-based therapies that we frequently employ in my clinic. So there's a fair amount of data that use of estrogen decreases blood loss. So the first thing that I do, particularly in a woman of menstrual age, is think about birth control pills. They tend to work reasonably well to slow down blood loss. The other drug that potentially is beneficial is a drug designed to treat breast cancer called tamoxifen. Tamoxifen has the added advantage that it reduces risk of breast cancer over time. And so in select populations, I find hormone therapy at least modestly effective. Those are good therapies for women. For men, we try to avoid them because they come with their own set of side effects. We'll use a fair number of antifibrinolytic agents. So the two most common are tranexamic acid, or Lysteta, and then aminocaproic acid, or Amicar. They come in capsules, they come in liquid, they come in IV formulations, so we can give them via a number of different modalities. The advantage of these drugs is that they help stabilize blood clots. So whenever someone forms a blood clot, as soon as that blood clotting process gets going, our body is actively remodeling that blood clot. We break it down and we build it up all at the same time. And if we slow down the process by which we're remodeling the blood clot and breaking it down, we can extend the length of the blood clot itself, and that can be effective at controlling some bleeding. We use a fair amount of anti-VEGF therapy at our institution for our most severe HHT patients. So in addition to giving Avastin in the nose, we can give it systemically. It's a really expensive therapy, but it's a really effective therapy in a subset of patients. And we've had very, very good success decreasing need for transfusions in a subset of very severe HHT patients. There's a number of other anti-VEGF therapies that are out there and are actively being investigated. So drugs like thalidomide and lenalidomide and pomalidomide are other drugs that are targeting the VEGF pathway, trying to slow down blood vessel growth and development. All right, so let's keep talking about our case. So our patient comes and sees us. Their hemoglobin seems lower than what it should be for their degree of epistaxis, and that's really always a concern to me. We know that nosebleeds are common in HHT. Now we have someone whose nosebleeds are really well controlled. We're doing exactly what we want, and yet their blood counts are falling. Well, where's that blood going, right? We said bleeding's the one concern that we always have. Could this be from the digestive tract? And it's really at that point when we have disproportionate amounts of anemia to the degree of nosebleeds that I think endoscopy is really important. So we have our patient undergo an upper endoscopy first. There's a small AVM in the stomach that we're able to treat. We do a colonoscopy because that didn't seem like that was the obvious cause of her anemia. So the question is, well, why does this patient continue to be anemic? And one of the things that we can see is that her iron levels keep getting worse. Her ferritin is now down to 9, and her iron saturation has continued to steadily fall. All right. The answer to this has to do with iron, and I will propose to you that while bleeding is really important in HHT, the worst cause of anemia in HHT isn't the bleeding itself. It's that over time, we lose our ability to produce red blood cells if we don't have iron. So in HHT, we have this two-sided problem. Yes, there's bleeding, but if we don't get on top of the iron problems, we also can't make new red blood cells to make up for the blood cells that we are losing. All right. So how much iron do we have? Well, blood is about 7% of our body weight. That's hard to believe, but it's a lot, right? You have a lot of blood in you, which means that the average adult male has about 5.5 liters of blood circulating through them, and a female has 4 liters of blood. So fairly large amount of blood that we all carry. And we know that iron is critically important to the function of blood. Iron is the molecule that binds oxygen and transports it through our system. And that's really the first and foremost property of blood. It's to take oxygen from our lungs and distribute it to the tissue. And it's iron that we need to do that. For the average person, we don't need that much iron every day because our bodies have elaborate mechanisms to recycle the iron that we have. Iron just so happens to be really hard to get into our system. More than 90% of the iron that we all ingest goes right through us, and it's only a small fraction of the iron that we take in from food our body is able to use. But because of that, we have this mechanism where when our blood cells die, we pull the iron that's in them out and recycle it. We repackage it and use it to make more blood cells. So if we're not bleeding at all, the average person only needs 1 milligram or 2 of iron each day because in addition to making blood, your GI tract uses a little bit of iron. You lose a little bit of iron through hair loss and skin loss, but it's really not very much because we're so good at recycling it. Menstruating females will have an increased iron demand because they'll lose iron with their menstrual cycles. The key for this, though, is to recognize that we don't really start running to problems with anemia until after we've depleted those stores. So we have stores of iron, we have iron in our blood, we have iron packed away in our liver, and as we slowly deplete those stores, we can run into the problem of anemia. All right, this is what iron does. It sits right in the middle of the hemoglobin protein. So this is hemoglobin. Hemoglobin is the molecule that binds oxygen, and right in the middle is the Fe, or iron molecule. Roughly speaking, 80% of our body's iron is in our blood supply, and then an additional 20% of it we have stored and packed away, classically in the liver, but also in the spleen and to a smaller extent in the bone marrow. We know that men have more iron in them than women on average, and that's fairly common. Iron deficiency is actually incredibly prevalent. We think of it as the world's most common nutritional deficiency. You're talking about a quarter of the world's population or more is iron deficient at any given time. And we know that women and then young people are at highest risk of iron deficiency. Well, why is this so common? Well, one of the main reasons is that absorption of iron, as we had mentioned, is really hard. We classically think of iron in red meat and liver, but it's also in chicken and pork and shellfish and eggs and greens. Particularly American diets are loaded with iron. The real trick is how do we get iron from the foods that we eat and into our bloodstreams. When persons have chronic blood loss, that increases their iron requirement because when we lose those red blood cells, the iron that's packed away in those cells is gone and it's lost. This really becomes the big issue in HHT. If we have lots of bleeding over time, we're going to eventually deplete our stores of iron. Well, what can we do to try to increase iron absorption? I think there are a few things. We know that one of the main roles of acid in our stomach is to convert iron into its ferric form. So we want to use the acid that's in stomach to help make iron more readily absorbed. This is potentially a problem because lots of us end up on drugs designed to lower stomach acid, right? We're on heartburn-based medications. Those will lower how much iron our bodies are able to absorb. So what can we do? Well, one of the things that we regularly tell people to do when they're taking iron tablets is to take your iron tablet with an acidic food source. So take it with a glass of orange juice or take it with tomato juice, take it with acid, and that will actually help overall iron absorption. How do we know if patients are iron deficient? Well, there's a whole set of symptoms that we get. We classically think of pallor. People look pale, or their heart will start racing. They'll have fatigue, and really the key to me is decrease in exercise tolerance. If you're used to being able to walk 2 miles and now you can only go 1 mile, that's a giant red flag. And all of us do some degree of exercise, right? This doesn't mean actually physically going out and exercising, but how much activity are you typically able to do? If you're used to moving around your house and now you've got to stop halfway up and down the stairs, that's a red flag to me. So if there's a change in how much functional work you can do, that's a classical sign of iron deficiency. There are a couple of other physiologic changes that we can see. We can see angular cheilitis, where you get kind of mouth sores on the corners of your lips. You can get tongue glossitis, where your tongue kind of smooths out. The classic symptom we hear most commonly is pica. About 50% of patients who are iron deficient will start craving to chew things, ice being the most common, but we'll hear stories of dirt, clay, newspaper, toothpicks. If you are chewing things, that's almost certainly because your iron levels are too low. We've seen all kinds of things. I had a nurse who was horribly iron deficient, and she had a bag of soil that she carried with her, and on her break, she would take soil and eat earth. We know that low iron levels can cause ringing in your ears. It decreases concentration in particular, so people feel fatigued and feel like they can't concentrate as well. And the other thing that we are now more and more recognizing is that muscle needs iron. So the main protein in muscle is called myoglobin. It is closely related to hemoglobin, and it also has an iron component to it. So if you are low on iron, literally your muscles cannot contract as forcefully as they can if there's enough iron supply. There's newer data in the last 3 or 4 years that suggests heart output improves when iron stores are replaced because your heart's just a big muscle, right? So if we can load your heart with iron, it will pump more effectively than if you don't have adequate iron supplies. All right, how do we make this diagnosis in the clinic? Well, there's a couple of things that we can see. Classically, to me as a hematologist, iron deficiency means you've got a microcytic hypochromic anemia. What the heck does that mean? That means the red blood cells are small in size. They're much smaller than what a typical red blood cell would look like. And they're hypochromic, meaning they're pale. They don't have that same amount of pink ring that typical red blood cells have, and we'll show you a slide of that in a second. Secondly, we can look at iron studies to clue us in. The best one of these is called ferritin, and there's problems with all of the iron studies. They're notoriously difficult, not technically to do, but there's a fair amount of fluctuation and variability in the labs themselves. So lots of things will cause ferritin levels to go up, namely inflammation and liver disease. And in iron deficiency, ferritin, which measures iron stores, should be low. So it becomes problematic when we're trying to check ferritin. If someone has an infection or has a liver problem or has some other inflammatory condition, ferritin levels will go up, and we can sometimes miss true iron deficiency. The other iron tests are challenging to interpret. Binding capacity and iron saturation are the ones that I find most helpful, and they have a distinct pattern. Iron saturation goes down in iron deficiency, whereas binding capacity goes up in iron deficiency. All right, here is a normal blood slide. So this is what we had shown you before, and I think the key is just, we'll look at the red cells here. We can see that most of them are round, and they've got that central pallor right in the middle. That's fairly normal. In the setting of iron deficiency, what we see is a fair number of very small red cells. So something like this you can see is much smaller, or this one here is much smaller than what we would typically find. This one here, much smaller. And then, so that means they're microcytic, they're little. But clearly these are hypochromic. The amount of central pallor, that donut appearance, has dramatically increased. So you can imagine there's just not very much protein in these cells. They don't have the hemoglobin in there that they should to bind oxygen. One of the other things that we'll see is we'll see variations in shape of the red blood cells as iron levels get low. So they tend to elongate. They look like footballs or cigars, what we call elliptocytes. So this one here has that kind of appearance. And then we can get very irregular forms. We can get ones that look like that there, or like this one here that kind of looks like a goldfish cracker. They take on unusual shapes and forms commonly in the setting of iron deficiency. So for me, this is the easiest way for me to tell if you're iron deficient. I just look at your blood under the microscope. All right. So when someone's iron deficient, what do we want to do? Well, we want to increase iron stores so that people start feeling better. I think iron deficiency, the symptoms are prevalent, and so often we hear the story of, well, let's treat your iron deficiency, you'll feel better. And I get this story, well, I didn't even know I was feeling bad until you gave me iron, and now I feel so much better, I don't have any idea how fatigued I was. We hear that story all the time. The other thing that we want to do, and I think it's really important in HHT, is I prefer to run patients' iron levels at the kind of high end of normal, right? Because we know that patients with HHT are going to have chronic bleeding issues, whether that's from the nose or whether that's from other sources in the GI tract. I want to build a cushion so that if you bleed and you drop your hemoglobin a couple of points, it's a lot safer to go from 14 to 12 than it is to go from 9 to 7. And so we want to give you a cushion. Remember, with HHT, it's not a blood disorder. There's no reason you shouldn't have a normal blood count, right? Every one of you should have a normal blood count if you have HHT. So how do we do this? How can we give iron? Well, there's really only 3 ways to give iron, and they all have their own sets of side effects. So we have to decide what's best for each individual person. First, we can give blood transfusions. All right? Red blood cell transfusions work well. They're the fastest type of therapy that we can use to get blood counts up. So if you're in trouble and you're having cardiovascular complications or serious pulmonary issues because you're anemic, we can absolutely give blood transfusions. And the advantage to a blood transfusion is, first, it gets your counts up quickly. And then secondly, if you remember, I had said our bodies recycle the iron that you get. You recycle the iron that you get from other people's blood too. So you can use that too. Each unit of blood has about 300 milligrams or so of iron in it. So it's actually a fairly effective iron treatment, but obviously blood transfusions have their own set of side effects. I don't think any of us want to regularly be getting other people's blood. So that leaves us with 2 other ways to get you iron, and those are pills and IVs, and we'll talk more about those here. So how do we figure out how much iron you need? Well, there are calculations that we can use that estimate how much iron. I use something called the Ganzoni calculation. It essentially says, what is a person's iron level now, and what do we want it to be based on their size? So iron happens to be weight-based. The bigger you are, the more iron that you're going to need. And so we can use a simple calculator to figure out how much iron you need. This is a bit of a problem in HHT because these calculators assume you're not losing any blood. They estimate how much iron you need to get your levels up. And if you continue to ooze, we actually are going to underestimate how much we give you because you're losing some. So for me, they're helpful to kind of give me a ballpark estimate of how much iron you're going to need, but they don't answer the full question. To give you some idea, if your hemoglobin is 9 and you're a male, the average person is 1,600 milligrams deficient. All right, so let's keep that in mind. So 9 is moderate, not quite severe, but moderate anemia. It's not mild for sure. And an average male would be about 1,600 milligrams deficient. So keep that number in mind as we talk about what strategies we could use. All right. So for severe iron deficiency, we can talk about blood transfusions. The biggest potential complications from red cells are actually in what we call alloimmunization. Yes, we worry about infections. About 1 in 100 persons who get a blood transfusion will have a fever. About 1 in 1,000 will get a rash. But the worrisome viral infections these days are quite rare. So HIV is about 1 in every 1.5 million units of blood. Hepatitis B and C are the 2 that I worry more about. They're still rare, 1 in 200,000 units of blood. So I don't worry too much about the infectious risk of blood, truth be told. I worry a little bit about it and try to avoid it whenever I can. But the big risk is what we call alloimmunization. So over time, your immune system wakens up to the fact that the blood cells that we've infused from other people aren't yours, and you'll develop antibodies against other people's blood, not based on the ABO matching that we do, but on the smaller antigens that are present on red cells. So Is that okay? Yes, that's okay for that unit of blood, but it makes finding the next unit of blood increasingly difficult. So the more units of blood that you've been exposed to over the course of your life, the harder and harder and harder it becomes to find appropriately matched blood cells. Blood's also not cheap. Of all the therapies we talk about, blood transfusions are by far the most expensive. They're much more expensive than either pill forms of iron, which is dirt cheap, or even IV iron, which some of us will think of as expensive. It's much, much, much less expensive than a blood transfusion. Each unit of blood is probably $2,500. We forget how expensive these treatments can be. Each unit. So if you get 2 units, that's $4 or $5,000. All right. So what about iron pills? Iron pills work okay. As we had mentioned, acid will help iron absorption, so we'll often tell people to take iron with an acidic food. And vitamin C helps iron absorption. We know that iron is best absorbed on an empty stomach. So ideally, I would tell you take your iron pill with a cup of orange juice, which has vitamin C and acid in it, or tomato juice, or pasta sauce, 2 hours before you have a meal, or 4 hours after your most recent meal. This is really hard, right? It's hard to find time in the day that's 2 hours or 4 hours away from a meal. And secondly, if you take iron tablets on an empty stomach, the GI side effects get way worse. All right? So I don't find that strategy very helpful at all. I usually tell people to take it with food to decrease the absorption. We know that iron is difficult on people's stomachs. It causes constipation in particular. It can also cause nausea and rarely can cause vomiting. The difficult thing about oral iron is it's the iron that causes this toxicity. So you'll see a number of preparations that advertise themselves as being easier to take and causing less GI side effects, medicines like Slow-Fee or a number of the preparations that are available over the counter. That's true. They're easier to tolerate because they have less iron in them. All right? And so if we take less, it's going to have fewer side effects. If you need more, it becomes a problem. One of the exciting things that we've learned, though, is we used to say, all right, start with 1 pill a day, and if that goes good, then increase it to 2 pills a day. And if that goes good, go up to 3 pills a day. And patients were trying to cram as much iron into them as they could. In the last 2 years, there's been 2 trials that have come out, one from the UK and one from the US, that has shown that if you take iron pills daily, you decrease over time how much iron you can absorb. And if you split your iron to every other day, you actually get the exact same amount of iron absorption as you would if you take these really high doses of oral iron. So these days, I'm often recommending patients take a day off. Take your iron one day and skip the next day. GI side effects come down, and the total amount of iron that you absorb actually is about the same if you skip a day. There are a number of iron preparations out there, ferrous fumarate, ferrous sulfate, ferrous gluconate. There's the liquid forms. Some people do find the liquid versions of iron, the elixirs, a little bit easier to tolerate. But one of the things that I caution you on is the dose, right? So when you take ferrous sulfate, which is the most common oral iron preparation, that's 325 milligrams, of which 260 are sulfate, so that doesn't count. It's only 65 milligrams of elemental iron in each tablet of iron. And if you remember, I think I said we absorb about 10% of iron. And that's true of iron pills too. So you're now absorbing with each pill of iron that you take 6 milligrams or so of iron. I told you before that the average male with a hemoglobin of 9 was 1,600 milligrams deficient. It takes a long time to replace iron stores if you're severely deficient with pill forms of iron. And that, to me, is the biggest drawback to the pills. It's the amount of iron that people are deficient. If we've replaced your iron and we've got you up and we just want to keep you up, then I think oral iron makes a lot of sense. We know that it's going to take a long time. The most common mistake that providers send to me are, we've had this patient, I've got their hemoglobin up, what should I do now? And they've just stopped the iron. I think you've got to stay on oral iron a fairly extended period of time if you're iron deficient, particularly in the setting of HHT where we're oozing all the time. The other question is, well, what do you do if it doesn't work, right? And that can happen. Well, I think one thing is maybe your bleeding's actually worse. Maybe there's more bleeding from the digestive tract that we're not aware of. So maybe that's a time to think about another set of endoscopies. Or maybe you can't really tolerate as much as you think you could because it's hard. So instead of getting in 3 or 5 pills a week, you're only getting in once a week. It's just not a lot of iron. And then the other issue is a fair number of patients just don't absorb iron very effectively. And in those patients, we got to think of a different mechanism to get iron in. So I use a fair amount or a lot of IV iron in my clinic. I think it has a ton of advantages over the pill forms for people with moderate or severe iron deficiency. All of this has to do with the fact that it comes in an IV, right? So when I give you an IV infusion of iron, you get 100% of what I give you. If I give you a pill, you get 10% of what I've prescribed. And because it goes in the IV, it has its own set of side effects, but it causes much less constipation in particular than the pill forms of iron. So we can correct iron deficiency much, much more quickly, and it's easy for me as a provider to know if you take it or not, because if you come into the clinic and you get your infusion, I know you got it. I don't have to count how many pills you took over the course of a week. That being said, it has its own set of side effects. It's not a perfect treatment. Historically, the biggest concern providers had with IV iron had a fairly high rate of allergic reactions, including anaphylaxis. We'll talk about how infrequent that is these days, because I don't see that as a disadvantage. The most common side effect I get in my clinic is muscle aches. So a fair number of patients will have muscle aches on the day that they get their iron infusions. It can cause headaches, it can cause blood pressure changes, it can make your urine brown. So on the day that you get it, if your urine turns brown, that's not anything to worry about, but we will see that. It is much more expensive than pill forms of iron. There's no way around that. And it can be a little bit inconvenient. There's something nice about sitting at your house and taking a pill. It's in many ways easier than coming into an infusion center, getting hooked up to an IV, even if the IV doesn't take very long to give these days. All right. I think IV iron has, within the medical community, had kind of a bad reputation, and I think that that's not really fair anymore. I kind of think of iron in terms of generations, at least the IV forms. So the oldest forms of IV iron have really been available for a long time, and they're based on iron dextran. This drug has a fairly high rate of allergic reactions and at least historically had about a 1% rate of severe anaphylaxis where patients' blood pressure would drop and they could potentially need to be resuscitated. That's not really fair. The newer forms of dextran have a much lower than 1% rate of anaphylaxis, but it's still problematic enough that we give, if we're using this iron, we're giving a test dose to patients to make sure they don't have severe allergic reactions to it. Don't use a lot of it, and in fact, in the last month we've had difficulty from the supplier acquiring the drug. They seem to not be making it as much as they once did. which is okay because we have newer and better iron sources. In the late 90s, there were a couple of newer iron formulations that came out, iron sucrose and ferric gluconate, which have been available. And the advantage to these drugs is that they have a much lower rate of allergic reactions. You don't need to give a test dose. You can give them fairly quickly. They come in fairly small doses. So ferric gluconate was originally licensed at 125 milligrams. So it's significantly lower than what Dextran is. I regularly, iron sucrose then is 200 milligrams on label, and I'll push that dose up to 200, 300, 400 milligrams at a time. And they're fairly effective medicines with a fairly low rate of iron reactions or allergic reactions. But the newer stuff I think works best. So these are the newest drugs, which are ferromoxetol, which is ferraheme, or ferric carboxymaltose, which is Injectafer, and they really combine the best of the first generation iron Dextran in that the dose is fairly high, and the second generation's that the allergic risk is fairly low. So ferraheme is 510 milligrams a dose. They recommend getting a second dose then 3 to 8 days after you give it. So you're getting 1,000 milligrams in the span of about a week. And the ferraheme, the Injectafer dose is even bigger. That's up to 750 milligrams. And you give that twice as well. So you're talking 1,500 milligrams of IV iron that you can give over the span of a week. If you're 1,600 milligrams deficient and I gave you 1,500 milligrams over the course of a week, that's pretty good. That's a lot faster than what we can do with pills that cause just a little bit. So I use a fair amount of the newest iron drugs. I think they're very effective therapies for a lot of patients, and by and large, very well tolerated. The side effects with the newest generation of irons are the same as they are with the old ones. Muscle aches most commonly, but the rate of allergies is really, really quite low. Anaphylaxis is really rare these days with the newest iron. You're talking 25 in 100,000 patients. That seems compatible across pretty much every brand and flavor of iron these days. There is a slight risk of infection, right? We're putting in IVs and dripping in drugs, so your risk of infection may go up just a hair, but it's really quite rare. So how do we do this? In my clinic, this is kind of the algorithm that we've developed and tried to follow in Milwaukee, where if we look and we think that you're bleeding, then we should go and look to see where are you bleeding from, and in HHT, if that means your anemia is disproportionate to your nosebleeds, then it's time to think about doing a scope. If you're a menstruating female, it's probably related to menstrual iron loss, in which case we should start you on an iron supplement. And then when we start, and I do start with an oral iron supplement in mild cases of anemia, you should respond within 6 weeks, so we'll repeat your levels just to make sure that you're improving, and if that's not the case, then we can think about moving on to IV iron. I calculate how much iron we think you're going to need, and then think about giving you either iron sucrose or ferric carboxymaltose or ferromoxetol, kind of based on your insurance, and we'll go from there. I don't think one of these drugs is better than another. Don't think one iron flavor works better for you than someone else's. Certain patients will have personal preferences based on convenience, and maybe they'll have had a side effect to one and not another, but it's hard for me to know which one is the right one. I wouldn't say there is a right iron prep. All right, so what about our case? Going back to our case, well, we have the patient, her hemoglobin is 9.2, even though she's not bleeding. I think what is going on is that slowly over time we had depleted her iron stores. Her iron stores had become low, so she wasn't able to produce new blood cells. So what's the right therapy? It's actually giving iron, right? We give her IV iron, we drive her hemoglobin back up to normal, we improve her iron labs, and she feels better. So in conclusion, we know that HHT is really anemia from two ends. It's bleeding, yes, but it's also not producing red blood cells adequately. We know that epistaxis is the most common cause of blood loss, less commonly associated with bleeding from the digestive tract, but that does occur. And we should go looking particularly if the anemia is disproportionate to the amount of epistaxis that you have. I think these days, iron deficiency is really common. We should aim to keep all of people with HHT at a normal hemoglobin and a normal iron level. There's no reason to not be normal, and that I use a lot of IV iron. So thank you, and I'm sure we'll have time for questions later on.
I have two questions. One is, since you're treating the iron levels and not the hemoglobin, do you have an issue with insurance companies?
Yeah, we'll do one at a time. How about that? I don't know that I'd say I treat iron levels. I think the single most important thing is symptoms, right? Symptoms trump labs every day. So if you're symptomatic from your anemia, that warrants treatment. And we know that patients, even with mild iron deficiency, anemia is one of the very last thing that happens when you become iron deficient. So you'll become tired, you'll start getting restless, you'll start getting pica and start chewing things before you become anemic. And I think that's actually a window to intervene before we drop levels. So I'd say we should treat symptoms, and we should treat iron. We should treat red cell levels a little bit, hemoglobin levels, but I don't know that I would necessarily wait for iron levels to fall. So we don't have too many problems with insurance these days. By and large, if we use the drugs appropriately, we can almost always get coverage.
Second question, patients that have no insurance or have a very high deductible, do you ever use the old-fashioned IM iron?
I never use IM iron personally because the rates of anaphylaxis are high, so I don't use it at all. What do we do in patients with difficulty getting these covered? It's really a problem. There's a couple of things that we can do. We can put you in the hospital. I can give you high doses of iron. And so I've done that on rare occasions. And the nice thing is that with the modern prep, you can get a fairly high dose of a iron product in, 500 or 750 milligrams, pretty quickly. And then, we're trying to game the system a little bit. The other thing to do there is really try to push pill forms of iron. Ferrous sulfate is really cheap. It's on everybody's $4 list. And so that's the other strategy. Pill forms work okay if we can get on it early.
Hi. I just had a question about, sorry, I'm talking too loud. When you're looking at a patient, what numbers do you look at? Because my hematologist looks at my hemoglobin and my ferritin levels. My brother, who doesn't go to the same hematologist, only looks at his hemoglobin levels. So when my ferritin levels start to drop, my hematologist gives me the iron right away. But with my brother, his will drop, and then his hemoglobin will start to drop. So what's recommended? Is there a regular?
I like looking at iron. So if we look at the HHT consensus guidelines, we say look at iron levels at least annually. And I think the reason to look at iron levels, in particular ferritin, is that while the lab can be a little bit labile, you'll get symptoms of iron deficiency before you're anemic. And if we're waiting for you to become anemic, we've missed this opportunity to keep you at a normal level. So I like your approach, your hematologist's approach better. That's more in line with what I would do in my clinic. We'll keep an eye on your ferritin. If that has been a good marker for you and we can follow it and trend it, if that starts to fall, that to me is the window to give you iron to keep you normal.
And just as a quick follow-up, so when you're saying tracking my iron level, the ferritin is my iron level.
Yeah, so the single best test that we can do to measure iron stores is ferritin. The worst test is the one that's labeled iron. So what I tell people to do is see the test that's called iron and just throw it out, because it's only going to confuse you. Ferritin is probably the best, although all of the iron studies they're less than ideal tests. There's lots of errors within the test themselves, so it's kind of a combination.
Hi, thank you for the talk. One comment and one question for you. So as a pulmonologist, I want to also mention one other, I think, important symptom that patients can get for a clue of iron deficiency, and that's restless leg syndrome or restless legs. It's a very common problem, and it is very much inherently linked with being low in iron. So I always ask my patients, I'm always amazed at how many of them are getting terrible night's sleep because their legs are fidgety, they wake up achy in the morning, their legs are cramping. So in addition to the pica and everything else that Dr. Foy mentioned, think about restless legs. And the ones that get educated on it, they call me and tell me, well, I need my iron now, my legs are bothering me again. So, and then my question for you is, sometimes I get a lot of resistance from patients wanting to get IV iron because they're convinced they bleed more after they get their IV iron. Is there really any truth to that, and what would be the mechanism if that's really the case?
So they bleed after they get an iron supplement? That's their argument? Infusion. Yeah, so I don't know. I don't know that there's data that validates this. I know that we've thought that as you get IV iron and your hematocrit rises and your blood pressure goes up, you could theoretically get more bleeding, more oozing from an AVM. I guess that's potentially possible. To me, the value should be keeping people's blood levels normal. Let's aim to keep a normal, right? Your blood should be normal. It's normal. I guess I haven't had a lot of that complaints, but I guess it's theoretically possible.
I just wanted to make a quick comment because you'd mentioned that you had what do people with no insurance do, and I wanted to let everyone know that I've had a success contacting companies that produce the iron and things like that, with them giving scholarships and things like that to me or to others so that you can get your iron infusions. My doctor, who is a hematologist, actually has one of the ladies in his office does outreach and make sure that they send you paperwork to fill out because you don't have insurance, and then you get free iron through the company. So.
Yeah, and that's a really good point. One of the sad things about medicine that is as drug prices have gone up, one of the good benefits of that is that the patient support services have also increased, and companies are interested in getting their product to you, and many of the iron companies do have a fairly good patient advocacy group where we can use those types of resources to help you get iron. Good point.
I just wanted to know if you've seen any difference in liquid iron versus pill form. My husband takes Floridix, which is a liquid extract formula, and he seems to think that that works better than the pills. I was wondering if you've seen any.
Yeah, so some patients will say that. Clearly there's data that suggests the liquid form of iron is a little bit easier to tolerate, and adherence rates to treatment protocols are a little bit better. So I think that is certainly a reasonable option, and there is some data that hints that it's maybe a little bit better than the pills.
Thank you, Dr. Foy.